Hi, my name is Chris Sutton, and I'm going to be doing my ortho video number 3. And first things first, presentation. And first things first is I'm going to do my machine check. I'm going to check my pipeline pressure, make sure that it's at least 50 psi and there's no crossover. And I'm also going to check my E-tank, make sure I have my key available, and also make sure my E-tank is at least halfway full, and it looks like it is. I'm also going to make sure I have my ambu bag available. In my suction, I'm going to connect that and make sure that that's working appropriately. It looks like it is. Okay, I'm also going to make sure I have my rescue meds, my apples, and also my extra airway if I need it. Extra airways if I need it. I'm also going to check my flow meters, my Leak 25, make sure those working appropriately. I'm also going to take out my bulb and do my low pressure check. And I want to make sure that there's no leaks between my flow meters or my vaporizers. So I'm also going to make sure my vaporizers are at least are adequately full, and I'm going to make sure I have AC power. It looks like I do. I'm also going to calibrate my O2 sensor, and I'm going to check my CO2 absorber, make sure that's not desiccated or exhausted. And I'm also going to check my monitor and my vent settings, make sure that they are appropriately set for this case. And I'm also going to check my inspiratory and expiratory valves. Now I'm going to go ahead and do my high pressure check. I'm going to include this white piece here, and I'm going to turn my machine to manual mode. I'm going to turn my APL valve all the way off, and I'm going to push my O2 flush until I have about 30 centimeters H2O, and make sure that holds for at least 10 seconds, and that looks adequate to me. Perfect. There's our machine check. All right, so now what we're going to do is we're going to come to our patient here. We have John Doe. He's a 30-year-old male. He has a BMI of 44, and that's based off of his height, 190 centimeters, and his weight, 90 kilograms. He's a pro baseball player who is coming in due to rotator cuff repair on his right shoulder, on his right rotator cuff. He has a history of tobacco use. His current medication, he's taking ibuprofen, labs. We took some recent labs for CBC, CMP, and they came back with the normal limits. We did a CT on his shoulder on his right shoulder, and that showed ligament tears in the rotator cuff. And so now I'm going to ask John some questions. Okay, John, I'm going to ask you some questions now. Do you have any medical problems with your heart, with your lungs, with your stomach, your abdomen, or any neurological issues? Have you had any previous surgeries? Have you or your family members had issues with anesthesia in the past? Have you or your family members had issues with something called malignant hyperthermia? What medications are you currently taking besides ibuprofen? What allergies do you have that you're aware of? What did you have for breakfast this morning? And John, are you able to climb 2 flights of stairs or walk 2 blocks without feeling winded? And now I'm going to do a physical assessment on John. John, can you open your mouth for me and stick out your tongue? Perfect. I'm seeing a Malapati score class 1. I'm also going to check his theramento distance, and it looks like it's greater than 7 centimeters. I'm also going to have, and John, can you, with your bottom, can you try to bite your upper lip with your bottom teeth? And it looks like, based off of that assessment, he has a class 1 for his upper lip bite test. For inter-incisor distance, he has about 3 fingers that I can fit in his mouth. And then for his neck length or girth, that is within normal limits. John, can you move your head side to side, up and down? It looks like he has full range. Okay, now I'm going to go ahead and auscultate his heart and his lungs, and they are within normal limits. I've determined that he has an ASA score 1, or class 1. So John, the plan for today is we're going to do something that's called an interscalene block. That's going to block the pain on your right shoulder. And then we're going to give you some medication to help you fall asleep. And then we're going to put something down your mouth into your throat to help you breathe. And to perform that, we're going to use a direct laryngoscopy for that intubation. So and then we're going to do general anesthesia after we've intubated them. For plan B, if general anesthesia is contraindicated, we can do sedation. So, John, the reason why some of the indications for doing interscalene block is rotator cuff tears. Also, some other indications are total shoulder arthroplasty, as well as proximal humerus, distal clavicle surgeries. Some of the risks that are pretty common, one of the main risks that are pretty common with interscalene blocks is Horner syndrome. There's also hoarseness, difficulty swallowing, shortness of breath as intrathecal injection, and then the benefits of having this block is if I'm able to get the block good from C5 to C7, I can get a complete shoulder block. Some of the alternatives for people with COPD, you can instead perform a suprascapular or axillary block. So I haven't performed the patient, and I have obtained consent for the procedures. So the equipment that I have in order to perform this block, I have prepared syringes, dosing, stopcock, 22 gauge Stimuplex needle, a sterile ultrasound probe cover, as well as a 3 MAC, 2 Miller, and 3 different airway sizes, 6.5, 7.7, as well as 7.5. Okay, so now for our pre-induction. In his left IV that we placed, I'm going to give him 2 milligrams of midazolam. Okay, John, this is going to help you relax and maybe go to sleep a little bit to be able to perform this block. So the patient should be alert enough to follow commands and inform me of unexpected pain. And so now I've transferred my patient to the OR, and I've connected the patient to a pulse ox, 3-lead EKG, as well as a non-invasive blood pressure cuff, and I've also connected him to 2 liters nasal cannula. And now what we're going to do is we're going to go ahead and do perform the block, and I'm going to identify my landmarks as well as where I want to insert my needle and place my local anesthetic. Okay, here we go. Make sure we adequately lube this here. All right, here we go. So I'm going to look at my landmarks here. It looks like I can see my sternocleidomastoid, my anterior scalene, and can you lift up your head? Perfect, and I can see my middle scalene here as well. And I'm going to look for my cricothyroid notch, and that's kind of where I'm going to start at that level, just as a landmark to help me begin. All right. Oops. Where do we got here? Let's go this way. There we go. All right, so I see my jugular vein, my internal jugular. I feel like I'm pretty darn close, so I'm going to go a little more posterior here. All right, I see them right there. That's a really good spot right there. So I see my middle scalene, I see my anterior scalene, I see my snowman right here. I'm hoping that's C5, C6, C7, and my internal jugular vein, and also my internal carotid over here. If I said internal jugular artery, I made a mistake. This is internal carotid and internal jugular. And this might be my sternocleidomastoid. Okay, so this is where I want to insert right here. Okay, so now that I've identified where I want to place my STEMI needle, Stimuplex needle, I'm going to go ahead and insert it in plane from lateral to medial through the middle scalene. And then for dosing, I want to give 2 mils of Marcaine, 0.375%. I'm going to first aspirate prior to injection, and I'm going to do 5 mil increments. Perfect, thank you. Okay, so now that we have performed the block, the interscalene block, I'm going to go ahead and pre-oxygenate my patient with 100% O2 for about 3 to 5 minutes. And while we're doing this, I'm going to go ahead and place and do my induction medications prior to intubation. So the induction medication is going to be using is 100 micrograms of fentanyl, and then 100 milligrams of propofol based off of 2 milligrams per kilogram. And then I'm gonna do 90 milligrams of succinylcholine based off of 1 milligram per kilogram. Okay. Okay, so now that my patient is adequately sedated after checking reflexes, that he has no reflexes, I'm gonna go ahead and perform my intubation here. All right, to assist me here, I'm gonna be using a stylet with my ET 7.5. I kinda wanna do this a little bit quick. So after I take the mask off, I wanna go ahead and insert my blade. I'm using my my 3 Mac blade. All right, so I lifted up the epiglottis and I can see my vocal cords with my ET tube and my stylet to kind of help guide it through. Go ahead and go through it. It looks like I'm through the vocal cords. Take my blade out, and then I'm going to take my stylet out. Insert this just a little bit more. It looks like we're at 24 centimeters. I'm going to go ahead and, so I've taped my eyes, and I'm going to take my tube, and I'm going to go ahead and connect him to the ventilator. I'm going to put it on manual mode, and then I'm going to auscultate for bilateral breath sounds. I'm also going to assess for end-tidal CO2 waveforms, and then I'm going to look for I'm going to look for chest rising as well. Okay, it looks like he's all set up, and I'm going to go ahead and put him in the position that the surgeon requested, which is the beach chair. And then I'm going to abduct his right arm. Okay, and I'm going to titrate the gas. I'm going to put on the sebum fluorine and put it to about 1.8%. But I'll titrate down based on the patient's clinical presentation, knowing they have a successful regional block, and I'll titrate the gases as needed. Okay, now we're at the end of the case. So we're gonna perform a deep extubation to ensure comfort of the patient, but we'll make sure the patient is within appropriate ventilator parameters. So from what I can observe, it looks like the patient is breathing on his own. So he's able to protect his airway. Prior to that, I did turn off my gases. We're gonna go ahead and get ready to extubate here. I'm gonna go ahead and suction. And something I forgot to mention is when I did put in my ET tube, I should have said that I inflated the cuff. And so now I'm going to deflate my cuff. Going to suction, and then I'm going to pull it out and just give another good suction. Perfect. And I'm going to go ahead and make sure that he's adequately ventilated here. And then I'll go ahead and put him on 4 liters nasal cannula. And now we're going to transfer him. We're going to transfer him over to the PACU, and I'm going to give report to Nurse Daniel. Okay, Nurse Daniel, we have John Doe, a 30-year-old male with no known allergies, who has a medical history of tobacco use. The surgeon did a rotator cuff repair on his right shoulder due to torn ligaments. He has a 20-gauge IV in his left forearm. He was stable intraoperatively. He had an estimated blood loss of 3 mils. He received about 500 mils preoperatively of LR, and then intraoperatively about 500 LR. We also gave 8 milligrams of dexamethasone after induction, as well as 4 milligrams of Zofran 30 minutes before the end of the case, and 15 milligrams of Toradol post-operatively. His last vital signs of the OR showed a blood pressure of 117/74, heart rate of 82, oxygen saturation 97% on 4 liters nasal cannula with a temperature of 36.5. Orders have been placed for IV fluids, PRN pain meds, early mobility, and routine post-op monitoring. What questions do you have? Thank you.